It's already 2 o'clock. Good afternoon. Happy New Year to all. So I'd like to welcome everybody to the first PEP Talk for the year 2022. Please mute yourself, but always show your video picture. Sign in your name, Facebook account, email address in the chat box. Include names of companions attending. Use chat box to ask questions and make comments while the pep talk is on. There'll be group picture taking at the start and end of the pep talk, so please show your face in the video. As a reminder, please take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. The link is already in the chat box. As a reminder, also 50 OLETE certificates will entitle one mentee to a voucher for ROJoson telemedical consultation. So let's now have a group picture taking before we start the lecture proper in 2 minutes. Please show your face now. Okay. 1, 2, 3. Okay. The regarding ROJoson PEP Talk, I have a patient empowerment program in which I'd like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP Talk. I completed the core course on October 9, 2021 last year. From October 23 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in Thyroid Cancer Management, or in the development of thyroid cancer, which is part of the cancer course. The empowerment objective is for the lay people to have understanding of the fundamentals and generalities in the development of thyroid cancer as a health disorder or medical disease. Definition of terms in the title and the limitation of the coverage of my talk, as I cannot cover everything. Number 1, fundamentals will mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced or future information. Generalities means general statements of information, not covering specifics and not too detailed. And development of thyroid cancer means appearance and growth of the thyroid cancer. The contents will be the following. Thyroid, what is thyroid cancer? How common? Different types? Possible and theorized causes? Can thyroid cancer be prevented? Who are at higher risk of developing thyroid cancer? Behavior? How does thyroid cancer kill the patient? Is thyroid cancer curable? What is thyroid cancer? The first topic. Thyroid cancer is a medical disease when some of the thyroid cells grow uncontrollably with a potential to invade the adjacent body tissues or organs and to spread to distant tissues or organs. Shown here is is an illustration of the usual thyroid gland located on the central neck. Okay. A thyroid cancer presents as a solid tumor and not as a liquid tumor like blood cancer. It is also known as thyroid malignancy or malignant tumor of the thyroid, just to differentiate it from what is known as benign tumor. A benign tumor of the thyroid gland does not invade or spread. How common is thyroid cancer? It ranks number 7 in the overall cancer cases in the Philippines. It's more common in females, rank of number 4, versus in males, rank number 17. Thyroid cancer comprises only 1% of all cancers. It's not as common as breast cancer. Most common, thyroid cancer is the most common among the endocrine gland malignancies. Okay. And when I say endocrine gland, these are the hormone producing glands like the adrenals, pancreas, parathyroids, thyroids. Okay. So thyroid cancer is the most common among these endocrine gland malignancies. What are the different types of thyroid cancer? Not all thyroid cancers are the same. It is important to know the specific type as this affects decisions on treatment and prognosis. The more common types of thyroid cancers in the Philippines, papillary carcinoma, about 90%, follicular carcinoma, 10%, anaplastic carcinoma, about 1%, and medullary carcinoma, less than 1%. The rare ones are the lymphomas and the squamous cell carcinomas. So the papillary, follicular, and anaplastic cancer or carcinomas originate from what is called the follicular cells, the main substance of the thyroid gland. There's a special cell in the thyroid gland which is called the C cell, and then from which the medullary carcinoma originates. What are the possible and theorized causes of thyroid cancer? Up to now, most of the time, nobody knows the exact cause of thyroid cancer developing in a patient, as most of the time, the cause is multifactorial. In only 5 to 10% are thyroid cancers due to inherited gene mutation from the parents. So 90 to 95% are sporadic. Only 5 to 10% are the inherited gene mutation. There's a higher incidence of hereditary as a cause in medullary thyroid carcinoma among the 4 types. But this cancer is rare in the Philippines. It's more common in the US. All diseases, including thyroid cancers, have underlying, antecedent, and immediate causes. All diseases have predisposing, precipitating, and perpetuating factors. However, it is difficult to pinpoint the exact cause, a single cause at that, as oftentimes the cause is multiple factors or multifactorial. At best, we can only theorize the possible causes and factors. For a patient with thyroid cancer, an example of an analysis of the possible causes will be the following. 1, genetic predisposition could be the underlying cause. Then long-term unhealthy lifestyle could be the antecedent cause or precipitating or perpetuating factor. And then the last step is the gene mutation. It's the immediate cause. Another example of an analysis for some patients, there's still a genetic predisposition, and then excessive exposure to radiation could be the antecedent and precipitating and perpetuating factor. And the last step is gene mutation, being the immediate cause for the cancer. The last one, scenario among patients with thyroid cancer, no genetic predisposition, but the underlying cause can be from chemicals, which may now become the antecedent cause or precipitating or perpetuating factors. And then gene mutation is again the last step that will trigger the formation of the thyroid cancer. At present states of the knowledge for sporadic case, not the inherited gene mutation from parents, it seems that the last ultimate or proximate cause of the cancer is changes or mutations to the DNA within the cells, the gene itself. Thus, one can say that thyroid cancer is a genetic disease just like any other cancer. That is, it is caused by changes to genes that control the way our cells function, especially how they grow and divide. The 3 most common theorized ways by which a gene mutation can instruct a healthy, normal cell to form cancer are the following. 1 is it allows rapid growth. There may be a gene mutation in the so-called oncogene, which can tell a cell to grow and divide more rapidly, and this can create many new cells that all have the same mutation. The other possible way is failure to stop the uncontrolled cell growth. Okay, there's a so-called tumor suppressor gene which try to stop it. So, but normally cells, the usual cells, the normal cells know when to stop growing, so that you just have the right number of each type of cells, and cancer cells lose control that tell them when to stop. So a mutation in the so-called tumor suppressor gene allows the cancer cells to continue growing and accumulating. The last step is makes mistake when repairing DNA errors. Usually we have the so-called DNA repair genes, which look for errors in the cell's DNA and make corrections. A mutation in this DNA repair gene may mean that other errors are not corrected, leading cells to become cancerous. So what causes gene mutation? Underlying and antecedent causes. What are the predisposing, precipitating factors? Basically, there are two general steps. Gene mutations can occur for several reasons. One is the gene mutations you're born with or at birth. Okay, so some of us will be born with a genetic mutation that we inherit from our parents. So this type of mutations fortunately account for only a small percentage of cancers. So this now becomes the underlying or predisposing cause. The more common gene mutations occur after birth. Okay? After we are born, a number of forces can cause gene mutations such as smoking, radiation, viruses, cancer-causing chemicals like carcinogens, hormones, chronic inflammations, etc. So this is what is called the antecedent, precipitating, and perpetuating cause. Most notorious of the environmental factors after birth causing gene mutation is radiation exposure. This is for the thyroid gland. Okay, so the excessive exposure to the radiation can increase the risk for thyroid cancer, especially papillary and follicular carcinomas. So there are about 4 ways in which radiation can lead to thyroid cancer. Okay, one is before 1950, they used to give low dose to moderate dose X-ray treatment to children with acne, tonsillitis, and other head and neck problems. Okay, nowadays they don't use this treatment anymore. But those who have undergone this treatment before 1950 will have a higher risk for thyroid cancer. Radiation therapy for Hodgkin lymphoma and other forms of lymphoma in the head and neck. This is the usual treatment for Hodgkin and other forms of lymphoma. If the patient has Hodgkin lymphoma and then he is radiated or she is radiated on the neck, then he is also at risk of developing thyroid cancer. Exposure to RAI or radioactive iodine, especially in childhood. So there are some doctors who give RAI to patients, to children. Okay. And then the last factor will be exposure to ionizing radiation, including radioactive fallout from atomic weapons testing during the 1950s and 1960s and nuclear power plant fallout. Examples include the recent one, not so recent, but quite recent, 1986 Chernobyl nuclear power plant accident in Russia, and the 2011 earthquake that damaged the nuclear power plant in Fukushima, Japan. So another source is the environmental release of iodine-131 from atomic weapon production plants. The gene mutations we are born with and that we acquire throughout life usually work together to cause cancer. Can thyroid cancer be prevented? Yes, but not all, not 100% preventable. As I said, thyroid cancers develop through multiple factors such as genetic predisposition and environmental factors that it is difficult to identify a sure shot specific one strategy or prevention, except this is for thyroid cancer, except for minimizing radiation exposure as much as possible. There are some things that can increase the risk of cancer that we cannot change. So this include the damaged DNA inherited from our parents, family history, getting radiation because of need for treatment for another disease like lymphoma. Though managing certain controllable factors, risk factors can lower the chance of developing thyroid cancers. Again, there's no guarantee, best effort. And who are at risk of developing thyroid cancer? The specific cause is not known and difficult to pinpoint. The preventive program will be to know the risk factors, know the controllable ones, and control and mitigate. So risk factors, if present, affect your chances of getting a thyroid cancer. But having a risk factors does not mean automatically that you will always get a thyroid cancer. Again, to emphasize, though managing certain controllable risk factors can lower the chance of developing thyroid cancer, but there's no guarantee. These are the uncontrollable risk factors. You cannot control your sex, so you being a female is a higher risk than males. Family history of thyroid cancers, inherited thyroid cancer gene from parents, and the need for radiation for treatment for another cancer. The controllable factors, the most common at the moment, still exposing, try to avoid exposing to excessive radiation, particularly to the head and neck. So mitigating tips on controllable risk factors, avoid excessive radiation therapy. That's the most practical advice that we can give at the moment. Okay. And then be in touch with reliable medical information on thyroid cancer risk and prevention, because we might be able to identify some more in the future. What are the behaviors of thyroid cancers? Once a thyroid cancer develops, it has the potential to invade, to grow and invade or infiltrate adjacent organs or tissues, and also the potential to spread to distant sites in the body. The rate of growth and spread of the cancer is dependent primarily on the behavior of the mutated gene, and secondarily on the presence of other promoting factors in the body, person's body, and the environment, like cancer-causing chemicals. The thyroid cancer that has spread to another place in the body is called metastatic cancer. The process by which the cancer spreads to other parts of the body is called metastasis. Metastatic cancer has the same name and the same type of cancer cells as the original one, the primary cancer. For example, when you have thyroid cancer that metastasizes to the lungs, we don't call it lung cancer, but we call it metastatic thyroid cancer. The behavior of the common types of thyroid cancers, I repeat, the common types are the papillary, follicular, and anaplastic. Medullary is not so common in the Philippines. For papillary and follicular thyroid cancers, these are usually slow growing, and then prognosis is very good. Okay. And then anaplastic cancers, this is not so common, about 1%, but usually they are fast growing. It can rapidly invade and spread to other parts of the body, and the prognosis is very, very poor. This is usually seen in the older age group. Papillary thyroid cancers usually spread via the lymph nodes or the lymph channels. That's why if you have lymph nodes on the neck and plus a thyroid mass, we have to suspect thyroid cancer. Follicular cancers usually spread via bloodstream. So they usually spread to the bones and to the lungs. Okay, these are the more common sites of metastasis. Okay, papillary can also spread to the bone and the lungs. How does a thyroid cancer kill a patient? It can directly kill a patient when it invades, because the thyroid cancer is located in the neck. If it's not removable, it cannot be removed anymore. It cannot be controlled by removing it. Then it will invade the airway to the point of asphyxiation. And also, it can spread to other organs, distant sites like the lungs, the bones, liver, and the brain, and stop them from functioning properly. Secondary causes will be, it can kill a patient through a secondary causes will be complications of surgery, complications of other forms of treatment such as chemotherapy if this is used, then infection due to compromised immune system, and then malnutrition. Is thyroid cancer curable? Before I answer this question, let's have a definition of medical cure. Medical cure conventionally is defined as a medical condition that's completely gone and will never come back. So for example, appendicitis, if you have appendicitis, doctors remove your appendix, you have been cured. If you have gallstones and the doctors remove your gallbladder with the stones, they don't usually recur anymore in the gallbladder because you don't have any gallbladder anymore. So you have been cured of the problem. For thyroid cancer, especially papillary and follicular ones, these are the patients who after treatment do not have their cancers coming back 10, 15 years after or even longer. So as I said, this carries a good prognosis, papillary and follicular. Okay, but strictly speaking, strictly speaking, because of 10, 15, 20 years, they can be considered cured. However, doctors, even with that 10, 20 years, do not want to categorically use the word cure. They just use the word in remission. So why do doctors do not guarantee cure? Because we don't know everything about the thyroid cancer as yet. Okay, the best knowledge is that it's caused by a gene. Okay, the exact mechanism is not yet known. So even those who have undergone targeted cancer therapy treatment on the molecular levels are not 100% successful. The usual cancer treatment modalities, if we, let's say surgery, radiotherapy, RAI, are strictly not treating the primary cause of the cancer. So for surgery, they just extirpate. For chemotherapy, they just kill the cancer with drugs. And then with radiotherapy, they just burn. Okay. If the primary cause is still around, there's always a possibility of recurrence after treatment, theoretically. Number three, no two cancers are the same. So each individual cancer possesses different biologic characteristics. Even cancers of the same type, let's say papillary cancers in two patients, same type and same extent, small ones, okay, they have different behaviors. Some are slow growing while some are fast growing. Usually the biologic behavior of the cancer is not known at the time of treatment. Okay. So we just base it on statistics or data or information gotten from other patients before, but only time will tell the outcome of the treatment, whether in terms of whether the cancer is slow growing or fast growing. After treatment, some cancer cells may remain somewhere in the body unnoticed, and patients are asymptomatic for a long time, even as long as 10, 20 years, but can eventually grow, divide, invade, and spread to distant areas and become a nuisance. This is what we call a recurrence. So at the time there are no symptoms, we use the word remission. We don't guarantee complete cure. Some cancers may be present, but unnoticed. Complete remission means that tests, physical exams, scans, okay, show that all signs of your cancer are gone. No evidence of presence. Some doctors refer complete remission as no evidence of disease and no evidence of recurrence. So it does not mean cure, just say no evidence of presence of a disease. Recurrence means that some cancer cells can remain unnoticed in the body for years after treatment. If a cancer returns after it has been in remission for 10, 20 years, then we call that a recurrence. So a cancer can recur in the same place. For thyroid cancer, it can recur on the neck, okay, as it was originally diagnosed, or it can recur in different parts of the body. Let's say the bone, it has metastasized to the bone or to the brain. So up to now, strictly speaking, sad to say, there is no true cure for cancer, no guarantee it will not recur. Patients do not talk of cure. They use the word remission if there are no signs of recurrence. But They, together with the patients, will always hope for a cure, especially for those cancers which are recognized, diagnosed, and treated early and with no track record of slow growth in behavior, such as papillary and follicular carcinoma. When you catch them early, okay, they have a good prognosis. So to boost the morale of the thyroid cancer patients, though, one may say the patient is cured already if there is no recurrence after 10 years or more, especially if it's 30 years after. So, but there's always exception to this. So long remission is usually seen in patients diagnosed and treated early, and especially those with papillary and follicular but not anaplastic and medullary carcinoma. Summary and conclusion and takeaway, I have expounded on the following topics, which I will not mention anymore. Just take a quick look. So takeaway in relation to patient empowerment, be always in touch with reliable medical information on the fundamentals and generalities in thyroid cancer development. Knowledge is power, it gives power. Use the 4Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to prevent thyroid cancer. To prevent thyroid cancer in terms of, at the moment, avoiding excessive exposure to radiation, and in case it is not prevented, to gain greater control over decisions in the management once you have it. Okay. So with that, I end my pep talk, fundamentals and generalities in thyroid cancer development. I hope I have empowered you to have a better understanding on the fundamentals and generalities in the development of thyroid cancer as a health disorder or medical disease. Before we go to the QA, reminder, please take the online learning cum evaluation test exercise for mastery of learning and have a perfect score to get a certificate like this. And then again, as a reminder, we are now on the, this is the 30th pep talk. So those who have attended all the pep talks has already 30 olete. Who pass the olete will have 30 olete already. So 20 to go. And if you get 50, you're entitled to 1 voucher for free ROJoson telemedical consultation. So let's now have a group picture taking before we start the QA and interactions. Okay, can you all show your face now? One, two, three. Okay, Pabos. Si Beth, si Aida. One. Ayan. Aida, pakita ka muna. 1, 2. Okay. I just save this for. Okay. So the floor is now open for questions, interactions, comments, anything that you want to discuss. We have about 28 minutes to have a discussion. Any questions?
Doc,
Oh, yeah.
how this is Chuchi.
Chuchi.
What is the first sign? What is the first sign usually that that will tell you give you a hint that you might have that? Yung
Thyroid
malaki na agad, or is
Ah.
there any?
Number one, if you go by the symptom directed, no, meaning yung self-examination of your own body, as we discussed last year, no. So when you are palpating your neck, no, okay, when you feel a lump, that's the first sign. That's the first thing that you have to to trigger to what do you call that, to drive you to suspect something, di ba? If there's a nodule, no, on the thyroid, no, okay. But remember that, but not all nodules, especially on the thyroid, no, majority 90% are still benign, no, okay.
Okay.
So, but the starting point will be a nodule or a buccal that you will feel on your thyroid gland. Okay. So when you swallow, you can feel a lump now that will glide between your fingers and the windpipe. Now, ganon. Pag may nakapa ka, have it checked already. No? And then as a physician, so we examine you. So we look for signs of cancer, no? Okay. So signs of cancer will be kung number one, kung matigas na matigas, no? Okay. Number two, kung merong lymph nodes sa side, no? Kung may lymph nodes sa side, as I said, pag may lymph nodes sa side, you suspect papillary thyroid cancer. No? Okay. So because that's the usual behavior of thyroid papillary cancer. Now, if you have a mass sa ulo, then you have a nodule here sa leeg, no, do sa thyroid, then we suspect follicular carcinoma. No? Okay. Then the other clue for thyroid cancer is that if you have hoarseness of voice, yung yung persistent na yung talagang usually malaki na yung bukol eh. Malaki na yung bukol sa thyroid gland mo, and it has already invade the nerve to the voice, to the larynx. No? So, di ba, I told you, cancer invades. No? If it invades the nerve, then you will have hoarseness of voice. Okay. So basically, these are the essential basic signs or clues for thyroid cancer. But the starting point is really a nodule. No, hindi yung malaki ha. Iba yung malaki. Yung tinatawag enlargement. No? Okay. May bukol, then we look for matigas, no? Kung may hoarseness, kung may associated lymph nodes, or merong associated mass in other parts of the body. Okay.
Okay. May I ask another question?
Sure.
I asked that question because our driver, our family driver, has enlarged parang what do you call this, thyroid gland. But his first manifestation, we didn't know that he had problems, that the problem was really the thyroid. He was suffering from his leg. He cannot move his leg, and sometimes ang baba-baba na ng kanyang what do you call that, yung when you eat banana, agad potassium. So there was a time ang baba ng potassium, so the doctors could not there was no clue for them kung ano yung what was going on with his body. And then the wife noticed na lumalaki dito. That was the only time we found out that he has a thyroid problem. But it was soft, unlike what you said na matigas. No, it was soft, and therefore parang, does that mean it's not cancerous, or it's not malignant if it's soft?
Now, there's always exceptions to the guide that I gave you, di ba? Okay. So 90% are matigas, no? But there 10% will be soft, no? Okay. But I think what's more important to know is, okay, I'll just show you some drawing, ha? Okay. We will go, actually, we will discuss this next time, pero okay na. So the thyroid gland is here, no? So we have to differentiate two types, no? Is it enlarged? Let's say the original size is this one. Nag-enlarge siya, no? Okay. So the other one is bukol, no? 1 or 2 or 3. Depende, no? Okay. So pag-enlarge ito, this enlargement. So this can be detected by just palpating the neck, no? So it will appear as symmetrical kasi you put your fingers, palpating fingers on both sides of your windpipe, di ba? Windpipe. So if you swallow, you will feel that both sides are enlarged, di ba? So you call that enlargement, no? But if you palpated one parang bukol, round, oval, or 2, then that's nodules, no?
Okay.
So ito yung pinaka-importante rito, no? Okay.
Yeah.
So when you talk about nodule, we now talk about cancer or not. Okay. Not cancer. Okay. So we have to look. So we have to look for clues for cancer, the ones that I told you, no? Apat.
Okay.
So if there is one of those clues, then you hold on to this. If not, then it's this one. Okay.
Okay.
Okay. Majority, as I said, 90% are benign in real life. No. Okay.
Okay.
No. Now, ito naman enlargement. These are due to kasi this thyroid gland produces hormones. No.
Yes.
Okay. Hormones. Okay. So it can either be excessive, or too little, di ba? So if it's too little, you call that hypothyroid. Hypo. And then even with hypo, lumalaki rin, no? Ang leg mo because it try to exert its production, eh, no? Parang yung kamay natin, pag ina-exert natin masyado, lumalaki, di ba? Ganon. So, excessive naman, talagang malaki at nagpo-produce ng sobrang dami ng thyroid hormones, excessive. No? Okay. So, this one is easier to recognize. No? Okay. So, you just have to look at the symptoms. No? Symptoms of hyperthyroid. Kung wala siyang symptoms, most likely it's either normal, euthyroid, or kulang, no? Euthyroid or kulang. Majority are euthyroid, even those with nodules, no? Okay. So excessive, yung mga signs of excessive will be okay, sudden weight loss, yung sudden, yung talagang payat na payat.
Payat.
No? Okay.
Yes.
Kasi because of the metabolism, no? Sobra.
Yes.
No? Number 2, yung palaging palpitation. Palpitation is one.
He felt that.
Okay. Yung heart rate niya mataas. Let's say more than 100 palagi. No?
Yes.
Okay. That could be a sign of hyperthyroid. No? Okay. And then the other ones will be more, yung mata lumuluwa. That could be a sign of hyperthyroid. No? Okay. Saka yung tremors. Yung kamay. Yung tremors. No?
Okay.
Okay, so those are the 4 common signs of clues for hyperthyroidism, no? Yung sudden weight loss, no? And then yung palpitations or increased heart rate, and then tremors, and then yung mata lumuluwa, no? Okay. Ganun. Ay, hindi yung potassium, iba yun, ha? Iba yung potassium. So, anong nangyari?
Oh, well, he consulted with an endocrinologist.
Yeah.
And
Okay.
it's he's being treated now. He's being
Alright.
given pills to I guess to manage the growth, and then later on I think he will have to either go through surgery or uh, radioactive.
Okay. So they consider radioactive already? So she was told,
Yes, yes.
naka-hyperthyroid siya.
Hyper, ano.
Hyper.
Kasi wala pa siyang biopsy or anything.
Hindi naman kailangan. If it's
Hindi kailangan.
if they strongly this can be confirmed by yung thyroid function test, T4, TSH.
Yes, yes.
Okay.
I think
kung mababa ito at mataas ito, excessive, no? Then hyperthyroid siya, no?
Okay.
So treatment will be medicine. Pag
Yes.
malaki na, surgery. And then the other one is radioactive iodine. At the moment,
Okay.
no? Okay.
Okay, I understand na very well. It's very well explained. Thank you very much po.
You're welcome. You're welcome. Okay. So, any other questions? Ladies, Beth, anything there?
Perla, I think, is raising her hand.
Okay.
Perla.
Who's raising his hand?
Perla, you're muted, Perla.
Okay, Perla.
Last 1999, doctor, I was operated by colloid adenomatous goiter.
Ikaw?
Yes, doctor. At the Manila Doctors Hospital.
Okay.
Since then, nagtitake ako ng Eltroxin 100.
Okay.
Pero ngayon, every 3 months, nagpupunta pa rin ako sa aking endocrinologist kasi yung aking TSH, nagpla-fluctuate ba? Last November, nagpunta ako sa aking endocrinologist, mababa yung aking TSH. So, ang ginawa niya, doktor, binawasan niya yung aking Eltroxin. Instead na 5 days, ginawa niyang 4 days na lang. Ganun ba yung doktor? Kasi minsan, mababa. Di ba pag mababa, doktor, sobra yung aking Eltroxin.
Yeah.
Palaging magkasunod na mababa. Kasi nagpa-check up ako kay Dr. Mirasol noon. Binawasan niyo yung Eltroxin ko, ginawa niyang 5 days. Nagpa-check up ako sa ibang doktor dito sa amin kasi because of the pandemic, mababa pa rin yung aking TSH. Ginawa na lang 4 days yung aking Eltroxin. Next month, magpapa-check up na naman ako. Bakit doktor ganun? Yung aking TSH is parang nagpla-fluctuate.
Okay. Number 1, to react, okay, as been shown by as I've been telling you in the pep talk, no, we doctors have so many mindsets, iba-ibang diskarte, di ba? Okay, that's number 1. Now, number 2, it all depends on your situation also, no, the real situation. Okay. When you talk about colloid nodule, it's a benign. That's the most common. 90% of thyroid nodules are colloid nodule. No? Okay. So, ang inoperahan ka for whatever reason, no? Minsan pwede naman hindi operahan, di ba? Okay, kasi benign, no? Okay, but naoperahan ka, ang question is, ano yung tinanggal sa iyo, yung buo o yung partial, no? If it's buo, then you are down to wala ka ng thyroid, no? So you're not producing thyroid hormones. You will end up being hypothyroid. So they need to replace it now, di ba? To replace it with thyroid hormones. Okay? So ano yung ginawa sa iyo? Total, subtotal?
Total, parang total, doktor total.
Okay. Total, mag-total, so replacement na lang. Okay? Okay, benign naman replacement. So kung sa akin, as I said, kaming doctor, iba-iba yung ano, kung for replacement na lang, we just have to titrate the medicine to give you the lowest possible dose that will maintain you on normal level of thyroid hormones, thyroid level, no? So kaya chine-check every now and then, chine-check yung ano mo, yung thyroid
TSH.
TSH, no? Ano,
Opo.
TSH lang chine-check, wala na yung T4.
Wala na po, Doktor.
Okay.
TSH palagi.
Iba-iba. Iba-iba nga yung doktor eh. No? Ako, pinapacheck ko pa yung T4 saka TSH. No? Kasi TSH kuminsan hindi siya accurate from my experience. No? I have to check your T4. No? Okay. So, pag mababa, but the way doctors interpret it, kung mababa ang TSH mo, ibig sabihin,
Sobra daw.
sobra kasi yung thyroid hormones mo, levothyroxine, sinusuppress yung TSH mo kasi sobra, no? So so babawasan and then hanggang tumaas yung TSH mo. Ganon.
Opo.
Okay? So yun ang procedural, no? Ita-titrate, no? Okay?
Opo.
So anong gusto mong mangyari?
Kasi nga, Doktor, yon binawasan niya yung itong present na endocrinologist ko dito sa Cavite, binawasan niya yung pag-take ko ng L-troxin ng instead na 5 days, ginawa niyang 4 days, Monday, Tuesday,
Ilang milligrams?
100, Doktor.
Oh,
Ginawa niyang Monday,
okay. Another
Tuesday.
approach, iba-iba nga eh. No? Sabi ko sa iba-iba, you just have to stick to one doctor whom you trust na lang. No? Kasi one approach is also, ibabawasan mo 50 to 50. Di ba? 100, gagawin mong 50. No? Kahit na everyday mo na lang inumin. No? Okay? Kung after 6 months na palaging normal na, then you don't have to have the test every 3 months anymore. Kasi yung laboratory results mo nagpa-fluctuate din eh based on the laboratory and based on your body. Maguguluhan ka lang. Okay.
Kasi parang sabi nila parang wala daw L-troxin na 50 mg, microgram.
Meron na, meron. Kung wala, ihatiin mo. Wala. Meron.
Meron po ba yun?
Oo. Kung wala niyan, Tidin, yung ibang brand. Meron.
Kung try ko kaya ulit, Doktor, na everyday na 50, okay lang kaya yun? Mag-change ako without my consent of my doctor?
Ikaw, number one, you have to consult a doctor whom you trust and stick to him. Kung wala, maguguluhan ka. If you see 2 doctors, 3 doctors, maguguluhan ka. Okay?
Okay, Doctor.
Okay. It's your decision. I'm not saying you should see me.
Okay, Doctor.
Okay. Okay. Any more questions? Any
Meron doc sa sa chat box from
Okay.
Deli Lim.
okay.
Doctor, if I have just my booster shot, will my immune system go down? Tapos follow-up question, I have my booster shot last Tuesday. I had my blood test 3 days after, and the results showed that my WBC is below the normal range. The WBC is low, 2.87, while normal is 3.98 to 10.04. How could we increase the WBC?
The first question is booster shot. It's supposed to improve your antibodies. No? So when you say increase your antibodies, then that means it tends to automatically, it means it will increase your resistance against COVID. No? Okay. Okay. So now, when yung mga blood tests, that's why I said don't go for blood tests so often na kung di naman kailangan, no? Okay. Especially if it's near the you have something, let's say nagpa-booster ka tapos magpapa-blood test ka, ma-affect yung values eh. Kasi yung mga results sa blood test, even the thyroid function test, depends on the day. Anytime, it can depend sa mood mo eh. No? Kung minsan nagpa-fluctuate yan eh. Hindi siya steady. No? Okay. So, if you have some events that came up before, example, ito, booster, nagpa-booster shot ka, huwag ka muna magpaano. magpa-WBC, CBC, di ba? Okay. Kung wala ka naman nararamdaman, no? Okay. So yung buwaba, probably it could be a reaction to the injection, no? Okay. So kung wala, if you don't feel anything naman, just observe, no? Okay. If you want, you just have to, if you're concerned with the low WBC, you can have your repeat WBC after 1 month. Ganon. Pero kung wala ka naman nararamdaman, okay lang. Just go on living, just go on eating healthy lifestyle, okay? Doing your healthy lifestyle, eating well nutritious foods, no? Okay? So don't worry about the lab results. Wag tayo masyadong too dependent on the lab results. Maguguluhan lang tayo. Okay. Basta tandaan nyo, if you take your CBC now, you take your CBC 2 hours after, iba-iba rin yung values noon. No? Hindi pare-pareho, no? Okay? Take note of that, no? Okay. And then it's dependent sa katawan mo, the time you take it, the time that your mood, no? And then kuminsan yung laboratory factor. Iba-iba kasing gumagawa, no? Okay. Okay. Any more?
Another one from Chris N. How about performing X-rays, ultrasounds, MRI po?
Or what?
Wala akong sinabi kung baka sa thyroid. Ano kaya ito? How about performing X-rays, ultrasounds, MRI po?
Nasa si Chris. Chris,
Does it, may follow-up question, does it remit radiation too? From Chris N.
Radiation yan.
Does it remit radiation? Yeah, yung CT scan may radiation. Okay. X-ray may radiation. Ultrasound wala. Okay? Okay. So, anong tanong mo? How about performing? Ganon.
Hi, Doc. Good afternoon. Sorry, nalala ko yung audio. Ang ibig sabihin, Doc, if performing x-rays, yung mga, ang ultrasound, no radiation po ba yun?
Ultrasound, walang radiation yon. It relies on sound waves na pumapasok sa katawan mo, then nagre-reflect siya, and then to create a picture of your body. No? Ganon.
How about MRI, Doc? Yung anong dapat?
MRI yun.
Quarterly ba?
Ha?
Kung halimbawa may x-ray, paulit-ulit, ganyan, nag-emit ba yun ng radiation sa body?
X-rays may
Delikado
radiation. X-rays may radiation. CT scan may radiation. MRI, magnetic resonance, wala. No? Okay. Okay. So do only sabi ko sa'yo, lahat ng test, no, laboratory tests have their benefit and then the risk. No, ibabalance mo lang yon, no? If it's not needed, don't go for it because you are subjecting yourself to the risk. No? Okay. Risk of radiation kung madalas magpa-X-ray. Pero kung kailangan magpa-X-ray, get it, go for it. Na kasi mas mataas ang benefit that you will you have to have the X-ray, no, compared to the risk, no. Okay. Ako ma. So you're talking about the radiation. You're talking about radiation, hindi yung performing X-ray, ultrasound, MRI for thyroid nodules. No? Hindi, no?
Opo, Doc. Ang x-ray po ba, Doc, ano yung safest in a year? Twice? Once?
Well, as much as possible, wala. Di ba? Kung di mo kailangan, di ba? Kahit na 10 years, wala. Di ba? Okay. But if you need it, no, hindi natawag ng indications. If you need it, do it. No? Basta mas malaki ang chance that you will get the benefit. No? Example, wala rito siya, no? So,
Chest X-ray.
example, a patient will have may fluid sa lungs. No? So, after matanggal yung fluid, i-repeat yung x-ray para makita kung wala na talaga. So it's really needed to get information, di ba? Okay. Now, kung after 1 month, no, buwabalik yung ano niya, nahirapan siya huminga, after 1 month and a half, no, this is an actual patient which I'm seeing now, no, okay, so nahirapan siya huminga, I have to repeat the x-ray kasi there's no way in which I will know kung anong nangyayari sa baga niya, di ba? Okay, at least yung x-ray has a minimal radiation compared to CT scan, no? So again, iwa-weigh mo rin yung yung mga factors na ano yung tama lang, ano yung sobrang dami, no? Okay? Okay?
Okay po, Doc. Thank you.
Any more?
Doc, pwede may follow-up question pa? Sorry.
Sige.
Kasi yung radiation, ay yung sa radiation na ano ko pa nakukuha siya din sa thyroid, nagiging source din siya bisan nagkakaroon ka ng thyroid cancer. Ngayon, sa situation po ng may mga CA, kasama po kasi yung mga x-rays, yung sa mga quarterly laboratories. Yun yung pinopoint ko kung safe ba, halimbawa, kailangan ba kasama yung x-ray kasi monitor yung lungs mo kung quarterly mag-perform ka ng x-ray.
Quarterly na x-ray, kung kailangan, go for it. Kasi yung tinasabing natin risk for thyroid cancer, yun yung mga sobrang dami. Sobrang daming exposure, no? Okay? Yung let's say radiation of the lymphoma, usually mga mga 4,000 rads yan, ganun, di ba? Marami yon. Pero yung x-ray lang, konti lang yung exposure mo, no? Okay. So pwede kung kailangan, no? Okay. But as much as possible, kung di kailangan, avoid it, di ba? Because we don't know whether you have a genetic predisposition to have thyroid cancer because of kahit na konting exposure to the X-ray. We don't know, no? Okay. Okay.
Noted po, clear. Thank you, Doc.
Okay. Ladies and
Doc, there's another question from Bellet del Rosario. Doc, I had a booster shot last Wednesday, and then a day after, I experienced fever, headache, and pain on the right side of my neck with a small lump near the collarbone. I am worried about it. Is it also the effect of the COVID vaccine?
Nandiyan pa ba yung lump mo? Nandiyan pa ba yung lump mo?
Dito pa po. Maliit din eh. Nung ko lang siya napansin, Doc, nung pagkaturok nga ho.
Is it a lump or is it part of your bone?
Hindi ho nagalaw ho siya. Parang bilog na maliit na gumagalaw.
Saan yung mo? Saan yung booster mo? Same side?
Dito, sa right din po.
Okay. So i-observe mo lang kasi kung minsan yung booster can cause mga lymph nodes.
Oo.
Okay.
Kasi masakit ho mula din sa kilikining ito. Paakit ko ngayon dito.
I-observe mo lang. Kung bago lang yan, i-observe mo lang for 2 weeks.
Okay po.
Okay? Baka side effect ng booster lang yan.
Okay. Salamat po.
Okay.
Another question, Doc, from Mayan Jose. Hi, Dr. Ray. When is the best time to have a mammogram after a booster in November 29, 2021?
Bakit mammogram ang pinag-usapan natin? Thyroid ang topic natin, ha? Tapos na tayo sa breast, di ba? Okay. Mamo.
Asking lang po, Doc, from my sister. For my sister pala.
So have a mammogram after booster. Pwedeng basta wala ka ng side effects ng booster mo, you can have your mammogram already. Anytime. No, kung kailangan. No, kung kailangan. Yung mammogram mo. No? Okay?
Thank you, Doc.
Okay.
From Delhi Lim, again from Delhi Lim, Doc, what is SGPT, ALT, kinetic, and SGOT? If it is above the normal level, what does that mean? Your liver had something wrong. SGPT is above normal, 44.80. The normal range is 10.35.
Okay.
While
Kasi-
my SGOT is also high, 2.87, normal range from 3.98, between 3.98 and 10.
As I said, yung mga laboratory examinations, maraming values na nare-report, no? You must know how to interpret, no? One is you have to interpret it on the assumption that they're not nagka-fluctuate siya every now and then, no? Let's say, baka pag pinakuha mo ito yung lab test mo after 1 week, no? Iba na naman yan, kahit na wala kang ginawa, no? Wala kang ibang ginawa, no? Okay? So, and then you also have to look at the kung gaano kataas ang elevations, no? Kung 1,000 over 50, konti lang, no? Yung 50 na upper limit, mataas na mataas yan, no? So, it's either alarming, talagang meron, problema, no? Then you have to correlate it with your mga symptoms sa katawan, no? Okay, kung wala kang symptoms, baka laboratory errors yun, no? Okay, bakit ang taas-taas? 1,000, kanon, example. So you have to question it, no? Okay. So for the moment, if I look at your konting elevation lang yan, no, don't worry muna. You just adjust yung mga diet mo, environmental, kasi yung SGOT, SGPT, it could reflect on your liver, no, status of the liver, and then sa pagkain mo, i-adjust mo na lang. O kumisan, due to the muscles, since you have baka booster dose ka lang, napagka ka ng booster dose, baka merong effect din sa SGOT, SGPT. No? So, for the moment, looking at the values, not too high, no? Could be variations lang, normal variations, no? So you don't have to worry. You don't have to worry. No?
Okay po. Another question related to thyroid from Sanaida Cabral. Doc, last end of October, nag-self-examine ako. May nakapa akong parang maga sa may neck. Nagpa-examine ako for thyroid. Negative naman. Nagpa-ultrasound ako. May nakitang slightly enlarged right lobe with cystic nodule.
Last October, nag-self-examine ako. Parang maga.
So, sa may neck.
And then, nagpa-examine ka. Anong ibig sabihin nagpa-examine ka?
Nagpa-check up po ako, Doc. Pinatest yung thyroid. Negative naman po siya.
Anong examination ginawa sa iyo?
TH po ba yun? Saka TS
TSH?
po. Oo.
Mali nga. Bakit TSH ang gagawin sa iyo? May nakapa yung doktor? May nakapa siya?
Wala naman po siya kasi hindi naman daw po sa sabi niya ganyan. Tinalulun niya ako kung may pain daw po ba o ano. Sabi ko meron.
Wala siyang nakapa?
Wala naman po.
Oh.
Yun nga, sabi niya para ma-sure mo para ma-sure natin pa-test nga daw po yung pa-lab test.
Pag bukol, hindi thyroid function test ang kinukuha. Yan ang rampant na practice ng mga doktor. T4, TSH, hindi kailangan 'yon, no? Okay? So, magkakagulo lang 'yon, no? Yung T4, TSH is for the function. Pag bukol, you're talking about cancer o hindi, kung may bukol o wala. So the best best way to investigate that is through an ultrasound. So nag-ultrasound ka, di ba? Oh, yun, may lumabas. Okay? So ultrasound, so sayang yung TSH, T4 mo. Okay? Gumastos ka lang. Okay? So, nagpa-ultrasound ka, slightly enlarged with cystic nodule. Okay, when you say cystic nodule, yan ba yung nakakapa mo?
Ngayon, Dok, wala hindi masyado ngayon. Pero nung po, parang sabi ko, parang malaki yung ano ko.
Okay. Observe mo na lang. Kasi when you say cystic nodule, normal din yan eh. Pwedeng normal din yan because of hormonal changes. No? Gano'ng kalaki ba yan? Cystic nodule nakalagay?
2.4, Doc. Ay,
2.4?
ay 5.1.
Hindi, yung nodule mismo. Huwag yung size ng thyroid.
2.4 by 1.7 cms, Doc.
Oh, dapat nakakapa yun. Hindi mo nakakapa.
Sa ngayon, Doc, wala akong ano.
Sa right side. Anyway, observe mo na lang muna kasi cystic naman nilagay eh. Pag when you say cystic, benign naman yan eh. No? Okay.
Thank you po, Doc.
Okay. Any more? No more?
Wala na po yata.
Okay. So, no more questions? So we'll
No
call
more
it.
question, Doc.
Okay. So we will call it a day. So